Greetings, online students. This is the last recording, the ears, nose, and throat for pediatric respiratory disorders. If you have any questions or concerns, please give me a call and I'll be glad to help you. Thanks. All right, so if you'll get your PowerPoint out and your book out, we'll get started. Now, again, this is the ears, nose, and throat disorders, and we're going to start out talking about infectious conjunctivitis. Sorry. All right, there are several types when we talk about different types, and it really depends upon the cause. You can have viral or bacterial. Bacterial is the most common, and it's where you get edema of the eyelids, reddened conjunctiva, enlarged nodes. You'll have a lot of discharge that will cause a lot of matting, especially when you wake up in the morning. The eyes will be matted shut. For older children, itching and burning is common complaints, and feeling of scratching, like it feels like they need to scratch it under their lids. Now, this is highly contagious. It goes from hand to eye contact, so good hand washing is imperative. With viral, it's usually bilateral in both eyes. Adenovirus is the most common cause of viral, and again, it spreads from hand to eye contact, so you want to make sure you're using good hand washing. Herpes simplex virus is also a common cause, and that one hurts if you get herpes in the eyes, I promise. Some of the things they'll do is steroid drops near the end. At the beginning, they can actually make it worse, and they really need to see an ophthalmologist if they are having herpes simplex in the eye. The allergic type, they've got intense itching, redness of the eyes with watery discharge, and a cobblestone appearance of the eye. And if you don't remember what cobblestone appearance of the eye is, you can Google that and find all kinds of good pictures. Treatment will be antibiotics, eye medications. For viral, it's mainly comfort. If it is the herpes simplex virus, they may put them on acyclovir. For the allergic type, they may have to put them on either systematic or topical antihistamines, steroids, decongestants, and mast cell stabilizers. That will help with the edema, the mast cell stabilizers. We're going to do a good assessment, good teaching, particularly good teaching of hand washing, the importance of not rubbing that eye, of getting prompt treatment. Of course, they don't need to be using contact lenses while they have the infection, and how to properly instill the eye drops. All right, so let's start out with otitis media. Otitis media, 90% of American children have at least one ear infection before the age of 7. The incidence is highest in children 6 months to 2 years, and usually peaks after the 2nd year of age. Now, this rarely occurs in children over 7 years old, and why is that? Well, if you think about it, what's going on with them developmentally by this time? The ears have actually formed correctly, so that the eustachian tube now is formed where they won't have the fluid going back into the middle ear, so the ear infections are less common. All right, as far as more common in the winter months, and why is that? And if you think about it, the winter months, they're going to have a lot more upper respiratory infections. And if they have more upper respiratory infections, then they're more likely to get that cold and for that fluid to back up into the ear. Another thing that we talked about that might precipitate otitis media, upper respiratory infection during the winter months, would be RSV. Risk factors, children who live in households that have a lot of family. Of course, children who are exposed to lots of other children during daycare. We tend to spread the germs. And children who are around smokers, secondhand smoke. In fact, passive smoke is thought to actually damage the mucosa of the nasopharyngeal and eustachian tube. So this blowing smoke in people's ears that have ear infections is probably not a good idea. thus increasing the susceptibility to bacterial and viral infections. So it actually can make it worse. Now, why do breastfed infants tend to have a lower incidence of otitis media as compared to formula fed? Remember in your immune globulins in your immunity lecture you learned about the presence of IgA, Andrea. Andrea, it helps prevent respiratory infections, particularly viral infections, and you get that from breast milk. And because of the position that they're in during breastfeeding, also decreases the number of infections. External otitis, or otitis externa, also known as. This is an inflammation or infection of the epithelium of the ear, the auricle, or the canal. So it's on the external outer part of the ear. This is more common in the summer months because it is actually caused by contaminated waters, and sometimes we call this swimmer's ear. Now, it can also be trauma from kicking at the ear as well. External otitis can be caused by infections, dermatitis, could be a combination, can be bacterial, fungal. The most common bacteria that you're going to see is Pseudomonas, E. coli, and Staph aureus. The most common fungi are Candida and Aspergillus. Now, clinical manifestations. If the drainage is a result of an infection caused by Pseudomonas, which we talked about it could be, then we're really going to expect it to be green in color and very musty smelling, so that will give that away. Otherwise, we would expect to see pain, especially when you move any part of the outer ear, the auricle, or put any kind of pressure to the tragus. They're going to really hurt. Again, the drainage can go anywhere from serous anguish to purulent to colored. Temperature elevations are common. And swelling of the ear canal to the point actually that it blocks hearing and causes dizziness is common. This is made by observation with the otoscope using the largest spectrum. They're going to do a culture and sensitivity if the drainage continues and it doesn't clear. Therapeutic management, one of the things we're going to give is Tylenol. Is it okay to give ibuprofen? Sure. In fact, a lot of your physicians now prefer to give ibuprofen because it has the anti-inflammatory properties, so it will decrease the swelling as well. And then if it's real bad, Tylenol with codeine for severe cases. They may be put on drops, ear drops, particularly Cipro. They may be put on topical antibiotics like neomycin, nystatin if it's a fungal infection. Almost always now they're given corticosteroids to decrease the inflammation and swelling. And if it's too bad and it's starting to go into the jaw or down the face, then they will actually give them systemic antibiotics. And we should see improvement with all of these interventions within 48 hours. Now, that's a good thing, bad thing. If they're avid swimmers, they need to stay out of the pool for at least a week, 5 to 7 days. So if they're feeling better in 48 hours, they're going to want to get back in. So you've got to make sure that they take all their antibiotics and they're cleared and out of the water for at least a week before they go back in. Nursing considerations, of course, careful handling and disposal of any material that's saturated with the drainage. If they're going to be getting eardrops, they need to be at room temperature. The tip of the dropper should not touch the auricle when you're administering it. And the ear should be positioned so that the drops can run down into the canal, and you want them to stay in that position for at least 2 minutes for it to get fully absorbed. You might want to remember those. Disorders of the middle ear and the mastoid. We've got some terminology here. We got OM, which means otitis media, AOM, which means acute otitis media, OME, which means otitis media with effusion, and then chronic otitis media with effusion. The most common problem of the middle ear is acute otitis media. Now, this is also known as the painful earful, is what we call this. And usually this is a childhood disease associated with, like I said, colds and sore throats and blockage of those eustachian tubes. Otitis media is a general term that just means inflammation of the ear. So if you see they've got otitis media, that means they got inflammation of the ear. But if you see they got AOM, acute otitis media, then that means that's the onset of ear pain marked by redness of the tympanic membrane. Now, if you'll remember, when y'all were looking at the tympanic membrane, it was a pearly gray in color. Now it will be bright red and bulging. Now it will be bright red and bulging. This talks in your book about otitis media starting on page 717 if you're wanting to look. Also, these terms are located on page 718 in your book if you're wanting to keep up. Now, otitis media with effusion, if you see OME, what that means is fluid that's in the middle ear without inflammation. So now, if you looked in there with the otoscope, you could almost see the fluid line, what we call fluid line. It would be round, not so much reddened, but there would be a line drawn, and you would actually be able to see fluid behind that. Chronic otitis media with effusion is any time it lasts longer than 3 months. So if it's an ear infection that's been lasting longer than 3 months, we call it chronic otitis media with effusion if there is fluid. So acute otitis media is often caused by Streptococcus pneumoniae, H. influenza, and Staphylococcus aureus. It is not known about the causes of the non-infectious type. They think it's mainly associated with those eustachian tubes becoming blocked, particularly during flu season or cold season when they get rhinitis, and the enlargement of the adenoids adding to that. The incidence for this is highest from ages 6 months to 2 years. And then you're going to see that decreasing with age. 75% of children seen by a pediatrician has had at least one episode of otitis media by 2 years of age. So this is very common to see in children. Again, it's very uncommon in children over 7 because the eustachian tubes have developed correctly. So, diagnostic evaluation. Just looking in the ear, then, how do I tell the difference between AOM, acute otitis media, and OME, otitis media with effusion? Well, if I was to look with the otoscope, the membrane would be intact, but again, it would be bright red and bulging. I would not be able to see the bony landmarks. Do you remember the bony landmarks? The umbo, the manubrium, and the short process of the malleus. I would also not be able to see the red light reflex that we talked, or the red light reflex, that's in the eye. The light reflex at 5 or 7 o'clock in the ear, depending upon which ear you're looking at. Now, otitis media with effusion, it will be slightly inflamed, but really it's more of a dull gray membrane. And you can see an obscured landmarks, so you're not going to get to see them very well. But again, you're going to see this visible fluid level behind the eardrum. So let's talk first about acute otitis media. They will have an earache, of course, fever, purulent discharge that may or may not be present, depending upon the type that's causing it. Now, otitis media with effusion, you may or may not see them complain of earache as much as fullness or pressure in the ear. And they'll complain of this popping. My ear just keeps popping. My ear keeps popping. That's otitis media with effusion. Again, you see that a lot after, especially in contaminated lakes and pools where kids get infections in the ear. Clinical manifestations, crying and irritability in the young infant. They will tend to rub, pull, and hold on to that ear and rub side to side a lot. Very difficult to console. You may even see a loss of appetite in these children. Now, crying and or verbally feeling of discomfort is common. Irritability, lethargy, and loss of appetite. With chronic otitis media, you have to watch for long-term sequelae such as hearing loss, difficulty communicating, and feeling of fullness, tinnitus, ringing in the ear, and vertigo may be present with chronic. It is not uncommon for children who have repeated ear infections to have some degree of hearing loss, or they have heard vowel sounds and consonant sounds distorted to actually where they really think that's what that sounds like. I know my child had it, and her W's, all her W's she thought were R sounds. So instead of saying the W, she would say the R. So everything instead of work, work. It's going to work. So you have to really make sure they get follow-up anytime children have had repeated otitis media growing up. Now, therapeutic management varies, and it's very disputable. Some actually do nothing. They do the watch and wait method. And actually, this is the one that the American Academy of Pediatrics supports, is the do nothing, watch and wait method. Wait 72 hours in a healthy infant greater than 6 months. Now, if they're less than that, of course, then they don't watch and wait as much. Analgesics, antipyretic drugs are given. Surgical, some believe in doing surgery, the TNAs, the tonsillectomies and adenoidectomies. Some believe in putting in the PE tubes, the pressure equalizer tubes. Some believe in making an incision in the eardrum and seeing if that relieves pressure. Some actually just treat it with antibiotics for 5 to 10 days, especially if they've had more than 3 ear infections in the past year, if they are positive for a respiratory culture and they're a high-risk patient. Now, some of this, again, is because of parents demanding antibiotics. If they are going to give antibiotics, amoxicillin is the drug of choice. And usually about 80 to 90 milligrams per kilogram a day, divided into BID doses. Zithromax can also be ordered. The one thing that's good about Zithromax, you get a single dose and you only have to take it for 5 days, so that's an increase in compliance. Augmentin is a good backup drug. And then they can also, give some of these meds as well. Now, a single dose of amrocefin has also been proven to be effective, which is a good thing with compliance. But they have done studies and research projects where they have shown that the amoxicillin actually does better. So even though you got to take it longer for a longer amount of days, it actually killed the bugs better than the rest of these medications. Prevention, Prevnar, of course, is our prevention as far as our vaccine. Now, why is follow-up evaluation so important? Because evaluating the effectiveness and treatment and identifying potential complications is important, like hearing impairments particularly. All right, so what about pressure equalizer tubes? Are they the cure-all, know-all, best thing that ever walked? Well, they have helped several patients, absolutely. But pressure equalizer tubes, have also not helped some children. And some children have had to have more than one set put in. They are inserted under general anesthesia. They facilitate drainage of fluid and they allow the ventilation of that middle ear to allow fluid to be drained. So it's kind of a substitute for the eustachian tubes in equalizing that pressure and allowing for that drainage to occur. And some children actually benefit from having a TNA done. They usually remain in place, these tubes, for about 6 to 12 months before they are spontaneously ejected. Now, you do need to describe that for the parents because a lot of times they're very bloody when they come out, so that may scare them. They need to be replaced if it keeps reoccurring. And again, it's not a cure. There can be bloody drainage again at the time of ejection, and be careful not to get in the water. Now, some of the newer tubes you can get in the water and swim, but no diving. So the use of earplugs is kind of controversial whether you should use earplugs or not. But because of the contamination, particularly if they're in like a lake, they will tell them to go ahead and put earplugs in. Again, some of the newer types you don't have to, but no diving. Interventions need to be directed towards the pain management, potential of skin integrity because of the drainage, depending upon how much they have. Interventions for PE tubes, which we just talked about, to facilitate drainage. Making sure you prevent complications like hearing loss by getting follow-up appointments. And lots of teaching and emotional support is important. Complications, you can see here a variety of complications. Conductive hearing loss, that's Ryan. We used to do the Ryan and Weber test, which now they say does not have a lot of validity in it. So they would need to go to a hearing, to go somewhere where they can actually check their hearing in a specialized area. A perforated and scarred eardrum can occur. And if you look in someone's eardrum and you see lots of white, then that is usually scar tissue. So anytime you look in someone's ear and you see lots of white, usually that's because they've had some scar tissue in there. Inflammation of the mastoid. They can get cyst-like lesions that can invade the auditory structure and cause hearing loss. And intracranial infections like meningitis can occur if you're not careful. So, what would you teach the family? Well, we want to protect that ear canal from water even during showers unless they've got the type that's waterproof. They need to avoid swimming till it's healed. They need to get adequate and early treatment of their upper respiratory infections. Don't insert objects into the ear. Q-tips are not a good thing. Avoid instilling outdated eardrops into the ear. You want to make sure if it's a young child, you're feeding them in the upright position, and promote, good hand washing. Alternative therapies, chiropractic is one of them that's out there. I know from personal experience, my child had repeated ear infections growing up, and they were fixing to put tubes in her ear. So I said, let me research this out. So I researched it out and found that chiropractic care had been proven in lots of cases to cure the ear infections, and children were not getting them anymore. So I went to a pediatric chiropractor, and sure enough, after 2 adjustments and a little bit of echinacea, which boosts the immunity, my child did not have another ear infection. So we got away from having to do the PE tubes. So you just want to get out there and investigate and make sure that you know what you're talking about and that you can give good data to support things. But that is an alternative therapy that does work. Massage helps with the pain. Again, echinacea, garlic, golden seal, some of these things that help boost immunity or fight off other things will also help. Some old folk remedies you know about. So anything come to mind? I've heard of people urinating in people's ear because of the pH and that helping. So as long as they're not harmful, it's okay. Now, if they're harmful, then we should stay away from them. All right, that's the end of the painful earful. If you have any questions or concerns about that, please get with me. Rhinitis, you can review this on your own. As far as for high points, I'm only going to give you 4 to remember. Number 1, it's caused by an inflammation of the mucous membranes in the nose. Dun, 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 dun. Caused by an inflammation of the mucous membranes of the nose. Number 2, you need to avoid the allergen or irritant that's causing it. You need to avoid the allergen or irritant that's causing it. Number 3, you need to know about proper use of the medications, particularly if it's because of allergies. They might be on like a Rhinocort inhaler, and you would want to make sure that you knew how to administer that. And y'all will be going over inhaler use in the adult lecture. And for best results, blow your nose before the nasal meds are given. For best results, blow your nose before the nasal meds are given. Foreign body in the nose. Oh my word, children love to put things up their nose. If you have a child that starts having unilateral purulent drainage that does not smell good, start investigating. Something has went up the nose. Now, certain things you have to be very careful about removing. They have put those little batteries up their nose, and those can cause tissue damage, so you got to be very careful when you're moving them. Marbles, rocks, peas, carrots, beans. Someone told me one time that a crayon, anything that can about get up their nose. So again, me and my child look at their nose. They've just started having this drainage, and it stinks so bad. Look up the nose. They have probably put something in their nose. Sometimes you actually even have to take them to ER to have it removed. Sinusitis, the location of pain with sinusitis. If we recall where our sinuses are at, maxillary, you're going to hurt under your eyes, in the front of your face, and your teeth will actually even hurt. If it's a frontal sinuses, then you're going to hurt over your eyebrows. Your ethmoid, your periorbital and frontal areas where you're going to hurt. And if it's your splenoid sinuses, behind the eyes and at the base and back of the skull will hurt. And I know I've even hurt there some. Medical management of sinusitis is aimed at the pain relief and controlling the infection. Tylenol is often given. It's advised since aspirin is associated with nasal polyps, we try to avoid aspirin. Broad spectrum antibiotics, nasal decongestions. One of the big things people are using now for sinusitis is nasal washings in the forms of neti potties. So if you don't know what a neti potty is, then I would Google that because it's very interesting to see someone use one. And surgical interventions may also be necessary. Now, if they have to have sinus surgery, they're going to get a drainage and an irrigation. And what they'll do is go in, and they can do this in the office or the clinic. That area is going to be anesthetized, and then a large gauge needle is going to be inserted under the inferior turbinate of the nose into the affected maxillary sinus. I don't know about you, but this sounds kind of painful. And fluid or pus will be withdrawn. If no drainage is present in the sinus, then it's irrigated with normal saline. And if drainage is present, it's still irrigated with saline. They can do the Caldwell procedure. That's cleaning out the maxillary sinus through an incision under the upper lip as well. And they can do a drainage of the ethmoid and splenoid sinuses if needed, where they just put the large gauge needle in there, they withdraw any kind of drainage, and then they irrigate it. Preoperatively, they're going to assess their level of knowledge. That's a teaching learning principle. NPO 6 to 8 hours. They're going to be on sedative medications. They're going to feel pressure when they wake up, not pain. People have told me it's pain. Nasal packing for 24 to 48 hours. Anytime you mess with the sinuses, then you're going to have bruising and swelling around the eyes and nose, what we call the raccoon eyes. Postoperatively, you want to position them on their side. They need to learn to spit up those secretions, not swallow them. Then later on, they can be put in mid-Fowlers, ice compressions to help with the swelling. Monitor them for complications, mouth care, and change that nasal pad, PRN. You want to encourage lots of fluid intake. You don't want these patients to get dehydrated on you. You also want to teach them to avoid blowing their nose for 48 hours after the packing's removed, to report signs of infections, and that's why they will not try to do this surgery anytime you have a cold, because they don't want you blowing your nose postoperatively. Now, you may have some tarry stools, and they need to know that because of the old blood that they're swallowing. They don't want to get constipated and do a lot of straining, so you want them on stool softeners, and they need to take all their medications as prescribed. Prevention, they need to avoid the factors that contributed to the sinusitis and instruct them in preparing an environment that's controlled, like, bedroom in the carpet if they're allergic to allergens. Then they may have to take that up. Get plenty of rest and fluids. Take medications as prescribed until they're all gone. And again, the best way to do it is maintain a constant room temperature with the humidity being controlled if at all possible. Nosebleeds, epistaxis. These usually originate from the anterior septum. Causes can be anywhere from forceful sneezing to nose picking, especially in children, and unfortunately some adults. Fractures, foreign body, rhinitis, and hypertension can cause this. Now, they did a study of 115 nurses and doctors, paramedics, and non-clinic staff from an emergency department. This was a big teaching hospital, and only 1 in 3, 33%, could demonstrate proper way to control a simple nosebleed during digital pressure. Among the trained nurses and medical staff, just 43% got it right. So how do you do that? You put it over, if you feel your nose, you go down till you don't feel that bony prominence anymore. Right below that, on both sides, you squeeze. You position the client sitting up with their head tilted slightly forward. and apply direct pressure, not backwards. Apply direct pressure over the soft outer portion of the nose against the midline septum for 5 to 10 minutes. Ice and cool compresses can also be applied. Cauterization may have to be used if they can't get it to stop, especially if it's a posterior bleed, because posterior bleeding can flow even out of one and both sides. A nosebleed that's usually confined to one side is usually anterior, but again, if they're starting to bleed out of both sides, and it's a posterior bleed. And that's usually because of some trauma. If they have a posterior bleed, then it is going to require more drastic measures than just soft outer tissue direct pressure. They also have topical vasoconstrictors that they can use to help with that as well. The big things remaining calm. If it is a posterior bleed, postnasal packing may have to be placed. If it's more profuse and harder to manage and more serious, they may use a tampon nasal pack. It's a dye compressed sponge that resembles a tampon that they put in their nose, has a string attached. Once the pack's inserted, the blood or nasal saline causes it to expand. They also have balloon packs, balloon tamponades that they use with a 14 French Foley catheter that will also clog that off. The big thing that you want to do, again, is be supportive during that nosebleed. All right, disorders of the pharynx and the tonsils, pharyngitis. This is an infection of the mucous membranes, of course, of the pharynx, and it usually occurs after you've had some rhinitis or sinusitis. About 90% of your cases is caused by a virus, with group A beta hemolytic strep being the most common. Now, you do need to know the difference between viral and bacterial. With viral, you may have a low-grade fever, but bacterial, a high fever. A gradual onset with viral, or you'll have a more abrupt onset with bacterial. There may be scant to no tonsillar exudate, so you look at the tonsils, have them say, ah, and there will be no exudate to a very scant amount. They may complain of a sore throat. With erythema, with bacteria, they'll have redness with white or yellow exudate present on the tonsils. Usually with viral, there's no rash. With bacterial, there may be a possible rash, petechiasis, particularly on the chest and the abdomen if it's related to strep. With viral, its associated symptoms are cough, rhinitis, soreness, and malaise. With bacterial, it's chills, malaise, and headache. The CBC count is usually normal or lower than normal, about 10,000 with viral, and it's higher than 12,000 with bacterial. With viral, you'll have a negative throat culture. For bacterial, you'll have a positive throat culture. And would you like to guess what positive for? Group A, beta hemolytic strep, because that's the most common thing. As far as complications, the two most serious complications that you're going to have to watch for is rheumatic fever and acute glomerular nephritis. And we've already talked about rheumatic fever and childhood infections, and you'll talk about acute glomerular nephritis when you talk about kidney, so I'm not going to go into that right now. Treatment for bacterial, of course, you're going to give antibiotics. Typically penicillin G or V, and there is a nursing alert in your book about giving penicillin G and not giving it intravenously, and I'll let you read up on that. 250 milligrams PO every 6 hours for 10 days, and that will do it. With viral, it's going to be supportive care, of course. And lots of people don't like to hear that word, viral, because they're convinced it's bacterial if they have any fever at all. Well, you can have some fever and it still be viral. I've known fever to get up and stay up for 2 weeks and it be a viral infection. But it is hard to convince sometimes that it is that. Comfort measures, warm gargles will help with the sore throat. Increasing your fluid intake to 2 to 3 liters a day will help. They are not contagious for 24 hours after the treatment is started. So if it's bacterial and they've been on antibiotics for 24 hours, they're no longer considered contagious. Any family member who develops a sore throat needs to be evaluated, and a lot of times they will treat them prophylactically as well. All right, tonsillitis is an inflammation of the tonsils and the lymphatic tissue. Functions we know of the tonsils and the adenoids is to help with the body's defense against infection. To help with the body's defense against infection. Now, this affects 5 to 10-year-olds most commonly. The acute form lasts 7 to 10 days and is most often caused by group A beta hemolytic strep or H influenza. Viruses can also cause tonsillitis, but mainly this is your main cause. As far as the clinical manifestations, we call them the kissing tonsils because they are at least at a grade 4 touching. Mild to severe sore throats, difficulty swallowing, fever, and swelling and tenderness of the lymph glands. Now, muscle and joint pain will also be present, and that swelling's in the submandibular, if you remember where you felt of your lymph chains in the neck. Chills, malaise, headache, a constricted feeling in the back of the throat. You always feel like something's there. And if you've ever had strep, you know how that feels. It's horrible. You can swallow, and you still feel like something's just clogged and stuck in your throat. It can also relate to difficulty breathing if you're not careful and it closes off. Chronic tonsillitis can result in recurrent sore throats, drainages, particularly on your tonsillar area, and it's related to frequent attacks of acute tonsillitis. Treatment for this would be rest, adequate fluids, administration of Tylenol, throat lozenges, warm gargles, and antibiotics. If it's chronic and it doesn't clear up, then they will look at doing a TNA, a tonsillectomy and adenoidectomy. Nursing considerations, immediately post-op, you want to position them on their abdomen or side. You need to remember that. Discharge, and that's just to help with the drainage. Discourage from coughing, which isn't easy to always do. They'll be getting analgesics for pain, and no red products orally. That's just to prevent anyone from mistaking it for any kind of bleeding. Postoperative hemorrhage, the most obvious early sign is this child, you walk in and they're just constantly swallowing. And that's because that blood's constantly trickling down their throat. If you're going to inspect it, be very careful because you can cause them to have laryngeal spasms and go into a complete obstruction. Hemorrhage usually occurs 5 to 10 days post-operatively. And that's because about 10 days out, they are feeling good, so they start eating all the stuff they shouldn't, and they rub those scabs off, and they start bleeding. Why would you check for smelling and taste? Because think of where you're at, because of the nerves that you may be messing with, that you may also mess with that. So like your facial nerve. The Croup Syndromes affect the laryngeal, the trachea, and the bronchi. And the characteristics that you would see with that would be hoarseness, barking, cough, and respiratory stridor. If you look on page 721 with me, and you are going to have to know this, because croup is just a term that's applied to a broad classification, meaning upper airway illness. So there's different types of them. The big ones are epiglottitis, LTB, and brachial tracheitis, acute bacterial tracheitis. These are the most common. You may also see acute spasmodic laryngitis as well. Your book also talks about later on obstructive sleep apnea. You've already had that, but you're welcome to read over that as well. There won't be any questions on the test. There will be some, though, over this chart on 721. Make sure that you know it for the exam. If you look here, the first one we're going to talk about is acute epiglottitis. This affects mainly your 2 to 5-year-olds, but varies, and it is bacterial in nature. A lot of times you'll see the Haemophilus influenza being a big one. Immunizations, of course, will help against that. You're going to see rapidly progressing onset of dysphagia. Stridor can develop. Drooling. Drooling is a big thing. High fever, toxic appearance, like they just look sick, and rapid pulse and respirations. These kids are very, very sick, and you have to watch them very, very closely. As far as treatment with these, then airway protection, we will give what's called racemic epinephrine, corticosteroids, fluids, antibiotics, and lots of reinsurance. Now, one of the big things that you want to remember with this is you want to avoid, and this is on page 721 under the nursing alert. If you're going to do a throat inspection, it should be attempted only when immediate endotracheal intubation can be performed, because they already have a partial block. If you go in and do something, then you can cause a complete obstruction. Most of the time we leave that to the physician of looking at these children. They're going to be in the tripod position it talks about in your book. The child will have a fever. They appear sicker than normal. They are sitting upright and leaning forward with their chin thrust out, their mouth open, and their tongue protruding. That's known as the tripod. Again, they're drooling a lot because they're having difficulty swallowing those excessive secretions. It tells you the nursing alert on page 721, the 3 clinical observations that are predictive of epiglottitis are absence of a spontaneous cough, presence of drooling, and agitation. So you've got a child sitting in the ER, they're in the tripod position, they're drooling, then you need to get them back quickly. This is considered a medical emergency, and you need to get them some humidification and some steroids and some things to keep them from going into acute complete obstruction. Humidification, like I said, is an excellent thing, and racemic epinephrine to decrease that swelling. If they order an x-ray on these children, you want to make sure that it's a portable x-ray. You wouldn't want them going down the hall and going into a complete obstruction on you. The next one is acute LTB. This occurs mainly in our infant or a child younger than 5, and viruses are the main agent. It is more a slow progression following an upper respiratory infection. You may see stridor, brassy cough, hoarseness, shortness of breath, restlessness, irritability, low-grade fever, and a non-toxic appearance. They're not going to appear like they look as sick. One of the earliest signs of increased respiratory distress is that restlessness, remember, and it's showing that they are very restless. So they can have respiratory distress with this. You want to get them some racemic epinephrine, corticosteroids, fluids, and again, reassurance for the parents. You want to encourage those parents to stay at the bedside as much as possible, because you want to keep that child's anxiety down and ease those respiratory efforts as much as you can. Acute spasmodic laryngitis or spasmodic croup occurs mainly in your 1 to 3 year olds. Viruses mainly, and this occurs more suddenly and at night. They'll be fine all day long, and then at night they'll have this horrible croup. Upper respiratory infections, croupy cough, stridor, hoarseness, dyspnea, restlessness. Symptoms: awakening the child, disappearing during the day. And this is pretty obvious when they've got the croup, and it's usually self-limited. Usually they do good if you go into a bathroom with high humidity, like turning on the water on shower and closing the door and letting the humidity will help. Now, if some people say coolness is better, so they'll take them out on like a cool night to decrease the edema. It's whichever works best for the child. Oral feedings, you have to be careful about, because especially during night, because they have a hard time breathing, and physical exertion becomes an issue. So, but it is self-limiting and usually clears within a few days. Acute tracheitis is the last one. This occurs in the 1 month to 6 years, can be viral or bacterial. Again, it has a croupy cough followed by upper respiratory infection. With this one, you will have some secretions and high fever, though, and no response to any of the therapy that would take care of the LTB. They're going to put them on antibiotics and fluid, because it is a lot of times bacterial in nature. So you do need to know that chart inside out. Again, for the rest of the chapter, read over some of this, but if I haven't covered it in the PowerPoint, then you don't have to know it, because some of this stuff we are covering in the adult. For example, like the pneumonias, so we're not going to cover it here because it's not a lot of difference. We've already covered whooping cough or pertussis on page 728. TB will be covered in the adult. And then the last part of the chapter from 731 on goes over foreign body aspirations and, the effects of cigarette smoking. Asthma and CF, will be lots of questions over that, which I have already done that. And then the last thing you'll see over here is CPR. So if you've forgotten how to do the CPR on the infant and the child, you may want to review that. If you have any questions or concerns, don't feel free to get in touch with me. Thanks. End of this section, and the good thing is, no more sections from me. Good luck.